Good morning, afternoon, and evening to all on the line right now. This is Mitchell Warren from AVAC, and I'm delighted to welcome you, along with colleagues from the Treatment Action Group, the WELL Project, and the Women's Research Initiative, to this webinar on debriefing the science of oral PrEP here in October 2019. I'm delighted to welcome you all. I know there are more joining, but we have many people on the line, and we have a lot of information to cover. So I think we're going to just dive right in. Given critical mass clearly assembled on the call and so many important issues to cover. Let me perhaps do a quick little run of show for today's call. I will just say up front that it is being recorded, so all of you should know that. We really want this to be as participatory as possible. We also recognize that it is a webinar, which has its challenge of interactivity, and we realize we only have an hour to cover a lot of ground. But I will say, and many of you will have seen this in the introduction to the call, this is the first of a two-part series, and we are excited to keep this conversation going. As I said, the we is the Treatment Action Group, the Women's Research Initiative, the WELL Project, and AVAC, and I'm delighted to welcome you on behalf of all of us to this call. They say, of course, that timing is everything, and this call's timing is quite important. We'd scheduled this call anyway for early October, and lo and behold, 60 days since the Food and Drug Administration's advisory committee to review Gilead's application for daily FTAF for PrEP, we received, as you all will know, the decision from the FDA at the end of last week, which recommends oral PrEP with FTAF as an additional option for some people, and we're going to really work to unpack a lot of that today. I do want to encourage people throughout the call to share your questions and comments. You can most easily, if you're on the Zoom interface, put in questions in the Q&A feature. We will get to as many of those as we can. And we will also be keeping track of those and be following up both with a second webinar, as well as, depending on the questions, we will find ways to get those answered through all of the organizations and the two fantastic resource people we have. We will, I'm going to, in just a minute, ask colleagues from TAG, WELL, and WRI to also say a quick hello and welcome before we turn it over to two presenters that we'll introduce in quick succession. Our hope is to get through those two presentations, one from Andrew Hill and one from Monica Gandhi, as quickly as we can without rushing them, so that we can preserve the latter half of the call for questions, answers, and conversation. And we will, as I say, get as far as we can with all of that. So that's really the logistics for the call. And before I introduce Andrew and Monica, let me first turn to Jeremiah Johnson from the Treatment Action Group to also provide a quick word of welcome.
Good morning. Can you hear me?
Yes, loudly and clearly.
Great. Yeah, don't want to distract from the great speakers we have today. I know we don't have much time, but I just wanted to say that, well, my name is Jeremiah Johnson. I'm the HIV Project Director at Treatment Action Group here in New York. And we're excited to help further this conversation today, to be part of this group presenting today. You know, we are in a time where there's a lot of misinformation out there about FTAF versus TDF FTC or Descovy versus Truvada. There are a lot of lawsuits on social media, a lot of, as a fellow advocate has said, ambulance chasers with a lot of misinformation out there about TDF FTC and the safety. We also know that Gilead, who owns Descovy and Truvada, is trying very hard to protect its domestic $2 billion a year PrEP market at a time when their stocks are declining after price gouging so many of us in our community around hepatitis C treatment over the past several years. So it's important for community advocates to understand what the evidence says, what the evidence doesn't say, and understand more about the communities that have been left out of this discussion thus far. In particular, cisgender women, trans men, transgender women, communities of color. These are all communities that we need to have more research in as we go forward. So we'll get to hear more about that today from people who are more knowledgeable than I, and really excited to be part of this conversation today.
Great. Thanks so much, Jeremiah. And many of you will know the WELL Project and its Women's Research Initiative is really pioneering work in the area of HIV research generally, and particularly with respect to women. I'm Dawn Averett, who leads the WELL Project, and Judy Auerbach, who's been core to the Women's Research Initiative, have been instrumental in working with us to plan this call. And I believe Judy, at a very early time on the West Coast of the United States, is on. And Judy, I don't know if you want to say a quick word of welcome as well.
Yes, thanks. Can you hear me?
Yes.
Great. Good morning, everyone, or good evening if you're somewhere else in the world. This is Judy Auerbach, and I am a sociologist and adjunct professor at the University of California, San Francisco, and work mostly as an independent consultant in the space that's sort of the nexus of science and policy in all things HIV, but particularly HIV prevention. I'm, in addition to my own work, my own interest in HIV, I'm joining this webinar as the co-chair of the board of directors of the WELL Project, HIV in Women, and as a member of the advisory group of our program, which is called the Women's Research Initiative on HIV and AIDS, also known as the WRI, as Mitchell mentioned. And just for those of you who are not familiar, the WELL Project is a nonprofit organization whose mission is to change the course of the HIV and AIDS pandemic through a unique and comprehensive focus on women and girls. And the WRI is a program of the WELL Project, and that program advocates for more, better, and faster research in HIV in women through a very unique and coordinated effort across disciplines, sectors, and organizations. And both of these were founded by Dawn Averett, as Mitchell mentioned. I'm sorry, there's a oh, there we go. So we're very pleased and honored to be co-hosting this webinar with AVAC and TAG. And as you might imagine, we're pleased to know about the approval based on some limited efficacy findings of Descovy for transgender women. But we're very concerned about what the lack of inclusion of cisgender women in Discover means for whether and how FTAF for PrEP will or should be an option for cisgender women. And the FDA decision on October 4th refers to particular sex acts rather than population groups, but leaves much unclear. So, for example, the approval explicitly includes FTAF for PrEP for, quote, persons who have receptive vaginal sex, which includes many, if not most, cis women, but said nothing about whether TAF should be recommended for cis women who have anal sex. It's just not very clear about that, so that's confusing to people we know. So it's important for all of us to understand the basic and the clinical science underlying the FDA's decision and how best to interpret it for all populations, and to think about this in the larger context of what already is available for PrEP for all at-risk persons to date. And this understanding, I think, will help us know how best to message these new developments to our various constituents, and to clarify what our near-term research advocacy agenda should be going forward. So I'd like to thank Monica Gandhi and Andrew Hill in advance for their presentations, which I know will be edifying, and my colleagues at AVAC and TAG for helping to host this webinar, and I look forward to a very robust discussion with everyone.
Great. Thank you so much, Judy. And as Judy said, we're going to take two really meaty and brief introductory presentations to set the stage and then have the conversation. Again, many questions will undoubtedly come up, and I encourage you to include those in the Q&A section of the Zoom interface. If you're not able to do that, feel free to email avac@avac.org, and we will put those questions in the queue. We're going to take this in two pieces. The first presentation is really looking at TAF compared to TDF, which is, of course, how the product was studied. And I'm delighted that Andrew Hill, who is from the UK, based at the Liverpool University in Liverpool, to present. He is a research fellow in pharmacology, and what gets thought about these drugs comes down to the pharmacology, and we're delighted to have Andrew present that first. And then we'll turn to Monica Gandhi from the University of California, San Francisco, who will be presenting specifically around FTAF and what we do and don't know about FTAF for cisgender women. So let me first turn to Andrew and welcome you, and thank you so much in advance.
Okay, thanks very much. So if you go on to the next slide, I work as a consultant for the World Health Organization looking at drug safety. And the World Health Organization is the most recent group to update international treatment guidelines. So in July 2019, they've recommended first-line treatment with only TDF and not TAF. So it's TDF, FTC, DTG, or TDF, 3TC, DTG, and PrEP with either TDF, FTC, or TDF, 3TC. TAF is explicitly not recommended for routine treatment of HIV by WHO, except in unusual situations, as that for people with impaired renal function or osteoporosis. Now, why have they not included TAF for general treatment? There are two clear reasons. The one is that there isn't a large enough safety database for treatment of TAF in pregnant women. We simply don't know whether there is a risk of birth defects or other adverse birth outcomes. And the second reason is that we have concerns over weight gain for people taking TAF versus TDF. Next slide. Just a little bit of history about TDF versus TAF. TDF was originally used in an unboosted form with drugs like efavirenz and dolutegravir that don't affect their pharmacokinetics. But most of the Gilead studies comparing TDF with TAF were boosted. The cobicistat and ritonavir increased the drug levels of TDF, which potentially increased the risk of adverse events such as bone fractures and renal problems. Next slide. If we look at the original Gilead studies of TDF, and this is a Gilead presentation for 7 years of follow-up. Next slide. You can see that when the drug is unboosted, is just used with either efavirenz or dolutegravir or even on its own, you see very minor changes in bone mineral density. And if you put these changes into predictive risk equations like FRAX, there is basically no predicted effect on bone fractures from unboosted tenofovir. Next slide. Similarly, if you look at renal function, there's a very small change in renal function early on, which basically stabilizes over time. Next slide. So these were the conclusions from Gilead, from their own study, after 7 years of therapy, saying that there were no discontinuations from TDF due to renal adverse events, no evidence of clinically relevant bone effects. And if you go on to the next slide, we did 2 meta-analyses comparing TDF and TAF and showed when the drugs were used without PK boosters, which is how they'd be used in PrEP, no significant difference in grade 1 to 4 or 3 to 4 laboratory or clinical adverse events, no difference in bone fractures or discontinuations for renal adverse events. Next slide. And similarly, you can see that if the drug's used as PrEP, you look at TDF versus placebo, and even then, across 22,730 person-years of follow-up, no significant difference in bone fractures, serious adverse events, creatinine elevations, just a tiny difference in grade 1 creatinine elevations, which are not generally considered to be clinically significant. So there are some people who are worried about the safety of TDF-FTC as PrEP, but if you look carefully at the randomized controlled studies, it's hard to find any real signal here. Next slide. Now, there's a flip side to this story. Next slide. You'll see it. Just keep going down. It's on a build. You'll see that when we look at TAF versus TDF, a lot of people are unaware that TAF actually is different from TDF. It causes greater rises in body weight, greater rises in lipids, glucose, and potentially a high risk of diabetes. And on the next slide, you can see the studies of TAF versus TDF in hepatitis B, where there was a significantly higher risk of grade 3 or 4, so severe elevations in urine glucose, in LDL cholesterol, across 2 studies quite consistently. And on the next slide, you can see in a study with protease inhibitors, this is TAF versus TDF, significantly more increases in LDL cholesterol, total cholesterol, and more cases of diabetes for people taking TAF versus TDF. Next slide. I was the statistician on a study called Advance. If you go on to the next slide, I'll just show you what's going on. So you can see across the board for TAF versus TDF, you get greater rises in body weight across a range of studies. On the next slide, you can see that TDF is more likely to cause weight loss, just slight weight loss, even compared to placebo. So TDF is driving the weight down, while if TAF is used with other drugs, it can drive the weight up. You can see the extent of this on the next two slides. We looked at a study called Advance. Yeah, keep going. We looked at a study called Advance, which is a randomized study, naive patients, 1,053, given either TAF or TDF with dolutegravir or efavirenz. And if you have a look now at the data for the women, on the next slide, you'll see the size of the increases in weight. Now, 10 kilograms is an average increase of 22 pounds. We work in kilograms. We had people with weight rises a lot greater than that for people taking TAF, FTC with dolutegravir. So you can see the extent of the increases, and this is in basically in African American or African women. Next slide. You can see in the next slide the increase in the risk of clinical obesity for people taking TAF dolutegravir. 1 in 4 of our women, after 96 weeks of treatment, became clinically obese taking TAF with dolutegravir. Next slide. There are a lot of this is not just asymptomatic weight gain. There are clinical implications of obesity, diabetes, myocardial infarction, Alzheimer's disease, a range of adverse birth outcomes. And remember, we don't have an adequate safety database of TAF in pregnancy, so we don't actually know the size of this risk at the moment. We can't quantify it, and there's potentially a reduction in life expectancy. Next slide. Now, there are various ways to predict these, the size of the risk, but we need to look at this in the future. We need to put all the weight data and glucose and lipids into risk equations and see just how much TAF could increase cardiovascular risk over time as a result of all these changes. Next slide. And the Frax equation, this is how you can predict the risk of bone fractures from changes in bone mineral density. And that's something that needs to be done as well. Next slide. So I guess, why do we need a new clinical trial of TDF FTC versus TAF FTC in cisgender women? We need to remember Truvada is already very well tolerated as PrEP in women. There's no clear difference from placebo in most of the safety parameters in meta-analysis. Will there actually be any significant benefit for TAF FTC at all? It's hard, given that Truvada is already the same as placebo in our meta-analysis, how could TAF be any better? There's no established safety database of TAF for pregnant women. There are concerns over safety of TAF in women, particularly weight gain, lipid elevations, glucose elevations, high risk of diabetes in one study. And then underlying all of that, you simply have the practicalities of if you're running a state medical program and you have the choice of either giving the generic, and in the UK, a month of generic Truvada is $50 or less, and then the branded version is 1,900. So you've got over 30 times increase increase in price to keep in the back of our minds. Next slide. So just in conclusion, it's not clear whether TAF has actually a better or a worse safety profile. It's quite possible you could run a randomized study and find that TAF is worse tolerated than TDF. And we've got a lot of suggestive evidence from other studies that that's happening. When TDF's used unboosted, there's no clear evidence for an increase in either bone fractures or grade 3-4 renal adverse events across thousands of patient years of follow-up. We need to look at these weight elevations, these lipid elevations, glucose on TAF, and see how much this could increase the risk of quite severe non-communicable diseases like myocardial infarction, diabetes, Alzheimer's, and birth defects. And actually already for African American women, TDF could be better tolerated, and that's probably why the World Health Organization is not including TAF in their current recommendations for treatment. That's the end of my talk. I hope I kept in time.
Andrew, you definitely kept in time, and remarkable amount of information covered in a brief period of time. Some great questions have come in, and I encourage people to continue to add to the Q&A section of Zoom, or again, email avac@avac.org. But before we open it up and engage in a conversation, let me now turn to Monica Gandhi from the University of California, San Francisco, who's actually going to be picking up on exactly where Andrew ended in terms of what we do and don't know and what might come next amongst cisgender women and FTAF.
Okay, thank you very much. Hopefully you can hear me well.
Yes, totally, Monica.
Okay, great. So in terms of PrEP and cisgender women, we start with the next slide. We start with the what do we know about PrEP effectiveness in cisgender women on TDF and FTC before it was approved. And then I want to go into how do sex differences in pharmacokinetics, how do they lead to the idea that we needed 7 doses a week? Because here, what happened with the FDA is that they didn't approve it because we didn't have studies in cisgender women of TAF, FTC. And after TDF, FTC was approved, there was a lot of decision-making that occurred on pharmacokinetics. Then I want to ask, what did the demonstration projects in women tell us? And then what do we know about the pharmacokinetics about TAF, FTC for PrEP in cisgender women? So next slide. So we're all familiar with the PrEP clinical trials that were performed that led up to the approval of TDF, FTC for PrEP. And the first one was, the IPREX was done in MSM, but all the others below were done in either women alone or a combination of women and men. Partners PrEP, TDF2, and Bangkok tenofovir were all done in men and women, with Partners PrEP really driving the approval for TDF FTC in heterosexual couples, including women. And then FemPrEP and Voice were done exclusively in high-risk women in Africa, or young sexually active women who are not in serodiscordant partnerships. And as you know, those particular trials showed no efficacy for TDF FTC in women. And that had not been true with the Partners PrEP and TDF2, which enrolled adequate numbers of women of heterosexual risk that we thought it would work in FemPrEP and Voice. So next slide. So it was surprising when FemPrEP and Voice both closed early and they didn't work. And really what the pharmacologic monitoring did and why we became so interested in measuring drug levels is because the drug levels in this particular case helped inform what was happening. Self-report to TDF FTC in Voice and FemPrEP was both high, and the return pill counts were both high, indicating high adherence. But looking at tenofovir levels in plasma, they were low in both studies, which indicated that likely the adherence was too low in those two studies, at least by adjudicated by an objective measure, plasma levels of tenofovir, to lead to efficacy. And so that was the explanation that was given in FemPrEP and Voice for why they did not reveal efficacy. And then next slide, please. It was a combination of those surprising findings in FemPrEP and Voice and the pharmacokinetic data that led to relatively long period of time where we had the dogma that women had to take higher frequency of TDF FTC doses than men. So if you look at the right-hand side, you can see that if you give the same dose of TDF to a woman and look at levels of cervical vaginal tenofovir levels, or even tenofovir diphosphate levels, which are the metabolite of tenofovir inside cells in the vagina and everywhere else in the body, you can see that those levels of tenofovir, as represented by the black bars on the left, are lower than the levels of tenofovir that you see in the rectal tissue when given a single dose of TDF and FTC to a male. And so that idea that there were lower levels of tenofovir in the cervical vaginal tract compared to the rectal tract led to a modeling study that said probably women need higher doses, higher numbers of doses of TDF FTC than men do for the same amount of efficacy. And modeling in IPREX Olay showed, for men at least, that probably 4 doses a week was okay for PrEP efficacy. And the relative dogma was that women needed 7 doses per week for efficacy, full daily adherence for this to work. And that dogma, again, was based on pharmacokinetic data that I show you here, and the idea that in FemPrEP and Voice, with the low adherence, the drug didn't work. And so the idea is maybe women in particular needed higher levels of adherence. And that was held in truth for quite a long time until just a couple of months ago at Mexico City, where 3 trials demonstration projects were presented in women for TDF FTC. And I want to go over those quickly because I think they could inform what we need to understand of what we know about pharmacokinetics, what we know in real life. And it's when you study a drug in trials or in real life or in demonstration projects, that's when you get closer to the truth than some of our models. So next slide, please. So what do the demonstration projects of PrEP with TDF FTC in women that were recently presented tell us? Next slide. So one study was the HPTN 082 study. And this was a study that looked at young women, 17 to 25 years old, Johannesburg, Cape Town in South Africa, and also in Harare, Zimbabwe, and asked the question, in these women, demonstration project being given TDF FTC, what was their adherence level, at least as measured by tenofovir diphosphate levels in dried blood spots, and what was their rate of seroconversion? So 400 women were enrolled who wanted to accept PrEP, and less than 200 women declined PrEP at enrollment. Next slide. And you could see that PrEP uptake with TDF FTC was actually quite high, very high in all 4 sites across the study. So that was extremely encouraging that women definitely wanted to take PrEP with TDF FTC, and they generally accepted PrEP when offered. Next slide. But importantly, at 3 months, 6 months, and 12 months, the levels of what we measure with TDF FTC, one common way to measure drug levels is to look at tenofovir diphosphate levels in dried blood spots. And you could see that they were detectable. The tenofovir diphosphate levels were detectable at 3 months at quite a high percentage of 84%. But at 3 months, 25% had levels that were consistent with taking 4 doses a week of TDF FTC. Next slide. And importantly, there were very few HIV seroconverters. The people on TDF FTC, women who seroconverted on these 404 person years of follow-up. There were 4 total that led to the HIV incidence being very low as compared to a calculation of a counterfactual HIV incidence without PrEP. And of those who seroconverted, they had very low levels of tenofovir diphosphate as measured in the dry blood spots. And the next slide, please. Oh, sorry, there was supposed to be a yellow box that said, maybe it's here actually, that importantly, oh, sorry, go back, sorry. No, 2 slides back. Here we go, thank you. So and the next slide, please. So in summary, very high PrEP uptake in the HPTN 082 study, and very importantly, very low incidence of HIV, despite the fact that women were taking around 4 doses a week. What I mean to say by this is this was the start of the demonstration projects that were just released that led to the question is we may have thought that women needed 7 doses a week of TDF FTC, but at least in these demonstration projects, 4 doses a week seemed to be enough. Next slide. The same finding occurred in the 3P study, which was another study done in South Africa, again of TDF FTC, which looked at women on that PrEP. There was a lot of risk. There was a lot of STDs. There were a lot of suspicion that the male partner had other partners. So this was a high-risk young population. Next slide. And again, the PrEP adherence as assessed by tenofovir diphosphate concentrations in dried blood spots was not 7 doses a week. It was more like 4 doses a week. And next slide. And importantly, there were no HIV seroconversions here as well, arguing again that we can model what we think we can by pharmacokinetic evaluation, but it was the pharmacodynamic evaluation, which is what happens in the real world with TDF FTC with women in these demonstration projects that gave us an idea that maybe they don't need 7 doses a week and maybe 4 doses a week is sufficient. And I'm building this argument because, again, the studies were not done with TAF FTC, but maybe we need those studies before we extrapolate from pharmacokinetic data. And I just want to correct that there was 1 seroconversion in the 3P study. Next slide. So what do we know about the pharmacokinetics for TAF before we get to the conclusions between Andrew and me about TAF FTC in women? Next slide. What we know is that at the mucosal layer and even at the blood layer, there are early events in HIV infection. And it's really the drug levels that are present at the site of entry that can be important. And there are also drug levels that are important in the plasma and circulating in the plasma that could be important to abort infection. Importantly, we don't know what is the target antiretroviral concentrations needed both in the plasma and at the level of the mucosa needed to abort infection. We do know this from TAF FTC versus TDF FTC. Next slide, please. Next slide. What we do know is that in plasma, if you give the same dose of TDF versus TAF, that you will see lower levels of tenofovir in plasma with TAF versus TDF, as shown in the left-hand panel. That is true of both men and women. What we also know is that if you give the same dose of either drug, that you will see higher levels of the metabolite tenofovir diphosphate inside cells with TAF than you will with TDF. That we've known from the drug company, that we've known from independent data sources. What we don't know is that putting it all together, what that means. And thus, any extrapolation that we want to make for women or men from the pharmacokinetics with TAF and FTC versus TDF FTC may not tell us what eventually happens in the real world with men and women, just like those 3 demonstration projects. Those 2 demonstration projects that I shared with you told us different things from the pharmacokinetics and what happened in demonstration projects. So I'll put this all together in my next slide in conclusions. It is important to say, and everyone on this call understands, that women are still underrepresented in clinical trials of new HIV medications. They were not included at all in the Discover trial, cisgender women, and the very, very low percentage and low number of transgender women were included in the Discover trial. But even prior to this, actually Gilead makes both albuterol and bictegravir. They had very low percentages of women enrolled in their pivotal START studies that led to the approval of both albuterol and bictegravir for treatment of HIV infection. The FDA chose to approve these drugs for women, but there was a lot of commentary from those who work in HIV in women that such low percentages were enrolled in these 2 trials for treatment for these 2 drugs. Only 8.3% of participants enrolled in cure studies, for example, are women. And when women are at the table to plan trials, women get enrolled. Next slide. So in conclusion, much is being said about TAF going to be more effective and should work for women because of what I just shared with you, that tenofovir diphosphate levels in peripheral blood mononuclear cells could be higher, but we do not know the PK correlate of efficacy. And indeed, the pharmacokinetic data for TDF FTC showed us that maybe 7 doses a week were needed, but the demonstration projects indicated that maybe women don't need to take that high of a level. So it's not having original data in women can hurt us, and it's why it's so important to do, and it's frustrating when we think about approvals for these drugs by the FDA. One option would have been that the FDA didn't approve this drug at all, awaiting the data in cisgender and women. And now we need to figure out our best approach for women, cisgender women, with the data that we have, which will likely involve clearly studies in women as well as careful pharmacokinetic data. And we need more work on the best correlates of efficacy. And I will end there.
Great, Monica, thank you. And again, thank you, Andrew. The two of you providing an enormous background for everyone. Lots of amazing questions have come in, and I do want to turn to those. I'm actually, if I may start with the very last one that just came in, because I wanted to give Dawn Everett a chance to weigh in on this. And actually, this last question actually is as if it were set up for you, Dawn. Why do you think that women are so underrepresented in these trials? And I know you have thought deeply about this over many years, and I wonder if you want to provide a perspective straight away.
Sure. Thanks, Mitchell. First of all, thanks to Monica and Andrew for those presentations and really kind of setting the stage. I think it is, of course, incredibly frustrating that we are at this place in 2019. And, you know, the approval, which included transgender women, which I feel like was a kind of a consolation prize in the whole thing, because there weren't very many transgender women in the study. This is just a huge problem, and it's a problem not only in terms of the work that Gilead did, but frankly, the role the FDA played in kind of saying, oh, well, this is really hard, so we are not going to enforce the participation of women. So to answer the question specifically, I think that we have to change the way we do clinical trials. And we've demonstrated that a number of times, starting almost 13 years ago with the initiation of the GRACE study, which was previously mentioned, and the Real MRK study and WAVES, and several other subsequent studies that have been predominantly post-marketing commitments. So the companies are able to go ahead and get drugs on the market and then are then out trying to figure out how to enroll women and people of color in clinical trials in order to answer some very important questions that, frankly, I believe should have been answered before the compounds hit the marketplace. And what we have shown in those studies is that it is possible to enroll women and people of color in clinical trials, but you have to do them a little bit differently than we have been doing them for decades now. And it starts with everything from how you design the study and what's in the protocol and who you engage in that process. So not just delivering a baked cake, but actually getting people in the kitchen. And when I say people, I mean specifically us. I mean women and people from the community who are living this every day, to think about what are the things that are compelling about being involved in clinical research, all the way to site selection, choosing sites where women get their care, and creating study narrative that actually is resonant for both the staff at the sites, as well as for those of us in the community who are going to be talking about these studies or potentially participating, all the way through how you do outreach and recruitment and enrollment. So I think that the reality is there hasn't been a silver bullet approach to clinical trials enrollment, but there is, frankly, something much more kind of granular and really about making small changes at every step of the process. That's to do clinical trials the way we've always done them. We can make modifications and still enroll populations that need to be represented. I think this particular issue has to do with the number of women that we would require in order to answer the questions. And frankly, this question is not a surprise to us. We should have been having very, very serious dialogues earlier, much earlier on, about how we begin to think about doing research just a little bit differently. I'll stop there.
Great, Dawn, thank you so much. And I think inherent in your comment there, something as we look at the end of this call and moving into the future, is what is the advocacy agenda? And it's clearly what you were describing, and so a lot of it obviously is around TAF for PrEP, it's around Gilead, but there are larger issues about FDA, about product developers generally, and product development pathways. And so really appreciate you saying that, because I think we need to be clear coming out of this as a community of what the very broad advocacy agenda is. So thanks for that. We've had, again, lots and lots of great questions coming in. And they cluster around some specific data questions related to TAF that came out of both Andrew and Monica's presentations, and then a number of kind of now what kind of questions. And I wonder if maybe take a round and just let both Andrew and Monica respond to some of the data questions, some of which I think maybe were done, Andrew, already in the chat feature, but I do think it'd be helpful just to get some clarity for all. But I think, this issue of did we see this weight gain? Again, I'll just go through some of these really quickly, and then maybe, Andrew, you can cluster them. Whether the advanced study, the weight gain was seen just in African women, or also if that study included African American women. So there's both in terms of who was in that trial. Similarly, some of the findings about bone mineral, glucose, cholesterol, glucose, cholesterol, did those trials see them in men as well as in women? Just to understand that, and how to best understand the difference in lipid levels between TAF and TDF. Is TAF actually increasing those levels, or is it simply canceling this TDF-associated lowering effect? A really interesting question. And then one more on the data piece. What do we know about weight gain and other metabolic effects associated with TAF and HIV negative individuals? Because, of course, those other trials that you referred to, Andrew, were amongst people using TAF as part of treatment regimens. And so a series of questions there. I know you picked apart some of those, but I wonder if you could maybe help just give us some clarifying points there.
Okay, sure. So just to go through them in turn. So in advance, and in another study called NAMSAL, which was similar in design, there were significant rises in weight in African women. So the advance was run in South Africa, including people from other African countries. NAMSAL was run in Cameroon. There have been studies in the United States looking at African American women, also showing rises in body weight for people taking integrase inhibitors. And so, I mean, my belief is this is happening across the board. Glucose in men and women, the largest studies of TAF in hepatitis B and with protease inhibitors recruited mainly men and showed these rises in glucose and LDL, a trend for higher risk of diabetes in one study. And in advance, we're seeing greater rises in both women and men, as far as I can see from the analysis. Is tenofovir simply lowering things and TAF just not being there, is almost being seen as an innocent bystander? I think it's an interesting question, but in a lot of these studies, all we know is that people are either taking TDF or TAF, and we're seeing greater rises with TAF. Now, I think we just need to look at the final result of this. We've got a population where we're seeing this increased risk of these markers that are associated with increased risks of cardiovascular disease, and we've got to take that seriously. I mean, grade 3 LDL elevation is a cause for concern. Grade 3-4 glucose, higher risks of diabetes. We need to try and get to the bottom of it, but I think we need to have more of an index of suspicion over TAF, given that this is happening. And then there was one about TAF in HIV negative. So in the Discover study, there was a greater rise in body weight for men taking TAF FTC versus TDF FTC. I haven't seen any data from Discover looking at lipids or glucose or risks of diabetes. I don't believe that Gilead has put that into the public domain. And this is a general theme that we see a lot of from Gilead about bone and renal, but there's very little data on body weight, on lipids, on glucose, diabetes actually in the public domain. We have to really search to find this stuff. That's everything.
Great, Andrew, thank you so much. And maybe, Monica, a series of related questions to your presentation about the data. And a couple of really interesting ones, and they relate also, I think, to how we think about the future of what trials need to be done and how to design them. But a great question about, for both the 082 and 3P studies, whether that observed lower incidence rate could have been due to a change in behavior associated with HIV risk. And again, one of the great challenges with those kinds of studies, how do we know what's really going on in outside of the more traditional randomized trial? So there's that. A question also about the decline in the diphosphate levels in 082 in particular at 6 and 12 months. And anyone looking at that slide would have seen a quite precipitous drop from 3 to 6 to 12. And a question about what that might mean, and question about adherence support. That's true probably no matter what PrEP product we use from an oral perspective, daily oral PrEP. And then finally, a question related to that in terms of what do you think, and again, that you've worked in this area so long, what we've learned about adherence, the lessons we've learned from these studies, and how they might shape and improve our design of future studies. And I wonder, that's a bunch of stuff there, but wonder if you might spend a little time on that.
Yeah, I mean, I think that it is true that in any study, including these studies in women, that adherence over time, or so-called persistence, or staying on the drug, wanes. And that is possibly also because of changes in risk behavior, but unfortunately it doesn't seem completely correlated with that, because in studies of MSM, stopping the drug or being less persistent is associated with new HIV incidents. So this degree of adherence and adherence over time, and providing adherence support over time, is an incredibly important one in the area of PrEP, and has to be thought of uniquely for men and women. But adherence interventions, adherence support, we need to force, work on for both men and women, and it may change. So it's several people have made this point, and I see Dr. Hardy's question. No doubt that I think adherence goes down over time in 6 and 12 months in these trials. In terms of other questions about whether risk behavior declined, that is, like you say, hard to measure and hard to tell. And these have only been presented in abstract form at the Mexico City International AIDS meeting. We do need the full publications of these to understand what was measured, and what if people who are in this demonstration project tended to, just from virtue of meeting with study investigators, will decline risk or use condoms more often. All of that has to be determined, hopefully, as much as we can gather the information, and you can't gather it completely. In terms of these questions that are also being raised on here about the amount of adherence needed for men and women, this is just hot off the press in terms of these demonstration projects showing such low rates of seroconversion. They were comparing their HIV incidence in 3P and HBT in 082 to calculated HIV incidence, kind of this counterfactual, they call it, what they thought would be if was happening without PrEP. And it raises that question of 4 doses a week. It raises that question that maybe you need less adherence. But it could be that women are smart about taking drug around the time of exposure, and 4 doses a week is completely fine if there was no exposure in other weeks, for example. So you can't, it's not a necessary conclusion. There's no doubt, I think, that pharmacokinetically that women have lower levels in the cervical-vaginal tract. What we're struggling with is what is needed. What do you need for tenofovir diphosphate levels of the cervical-vaginal tract? Is it tenofovir levels in plasma that matter? By the time you get into the mucosa, we don't know enough about this. So the research agenda is not just doing doing studies in women, which I think every single person on this call agrees that this was really frustrating that this didn't happen. But also, what are the exact correlates of efficacy in terms of levels? And that will involve more PK work. It involves giving men and women doses of drug, and looking at the drug distribute in different biomatrices throughout the body, and then correlating that with efficacy from other trials where we had already had those values measured and people didn't seroconvert. It's kind of complicated, but we're going to have to do it.
Great. I want to come back to maybe ask one quick side effect question, maybe for Andrew, and then have both Andrew and Monica, both of you respond to follow on to what you just said, Monica. So, quick question about a publication that came out earlier this year about actual hair loss in a study of TAF, I believe a treatment study, and wonder if that has been an established documented side effect. So, a very particular question there. And then this question, I think, came in actually a separate email related to something you said, Monica, about what levels matter. And I know you covered it, but it may be helpful for both you and Andrew just to both give a perspective on the difference between the tissue levels, and you showed the tissue levels of TDF differently in the two different compartments, but what levels matter, and do we know, and if we don't, how might we get more quickly to know what matters, the actual tissue levels or the actual diphosphate drug levels in the cells? And I wonder if either of you want to opine about that.
Yeah, so I can answer about the hair loss. The problem with the Gilead trials is that when you look for the safety, it's basically hidden. You look on clinicaltrials.gov, and any adverse event that's below a 5% prevalence is just not listed. So if there's a rare adverse event that might be different between two arms, you simply won't see it. There are other companies that are more transparent, but not the Gilead studies. So I can't comment on that.
In terms of the second question, I really want to give credit to Connie Kellum, who has done so much great work with these demonstration projects. And the way that her group at UW is going to try to answer the question that you just posed again is you go back in time and look at the studies where things went well and see if you can get at exact correlates of efficacy. So for example, in Partners PrEP, things went very well. There was high levels of adherence by both men and women in the design of the Partners PrEP trial. The individual who was not living with HIV had a partner that they knew the status of their partner who was living with HIV. So there's a lot of motivation for adherence when you're in a serodiscordant partnership. And the levels of adherence were high, and therefore the rates of efficacy for both men and women in that study were very high. So they will be going back after these demonstration projects now and looking carefully at the levels of adherence in Partners PrEP. In the study, they published plasma levels of tenofovir being correlated with efficacy. But luckily, they do have dried blood spots in that trial, I just recently found out. And they will be looking at tenofovir diphosphate levels of both men and women and what was needed for efficacy. In a completed trial, you can say, look, we know what worked. We know that this worked. We know we know efficacy. It's a done trial. We know who seroconverted. And so then you can get a hint by looking back at old drug levels to say, oh, look, maybe women did need the same amount of adherence that men did for the same levels of efficacy. Those are the only ways to go back in time and look. And so what did that require? Yes, of course, it required a large completed trial that was done in both men and women, which enables those kind of look backs at times. So I don't think we can get off this call without saying that that more study in women isn't needed for TAF FTC. It was why it wasn't approved. And I think there's been a commitment made right after the approval that Gilead said they will study it in cisgender women. But I don't know exactly what that will look like. And I think we can say that we wish it had happened before, but now we have to figure out moving forward what's the best approach.
Yeah, just one other comment about the
Go ahead,
just one other comment about the drug levels. So if you look at TAF versus TDF as a treatment, there is this claim that the diphosphate levels are higher with TAF, and that might have clinical significance. But if you look at rates of viral suppression for people taking either type of tenofovir, there's just no difference at all. So to the extent that you could extrapolate, we've got thousands of patient years of experience and just no difference between TAF and TDF for treatment, despite that difference in the diphosphate.
Yeah, I want to comment. I think that's a very important point, that you can't say, well, efficacy is correlated with tenofovir diphosphate, so TAF is more effective, but adverse effects are associated with tenofovir in plasma, so that's why it's less toxic. That's a very convenient claim, but we really don't know what the correlates of efficacy are. And Andrew's point is very good that if it's not more effective, then we should be looking at both safety and efficacy.
Yeah, it's a great point. I know many people actually at the advisory committee meeting 60 days ago talked very importantly about this, that we're talking about a non-inferior finding in efficacy and a different safety profile, not a safer, better drug. And I think, I know Jim Pickett has spoken about this rightly many times, and it's in the chat function as well, about how we as advocates are making sure that we stay vigilant about what we say about that. There's obviously a lot more coming in. I know a couple people do have to drop, including you, Monica, at the top of the hour. I do want to get to one. Recommended as an option by the World Health Organization, at least for TDF, FTC. Oh, I hope you can hear me still. But a question about 211 dosing for event-driven dosing with TAF, and I don't know, Alan, if you want to comment on that at all.
No, I think that's it. What I was just asking about is, you know, there's a large gap of information in the use of Descovy as 211. You know, we have Ibergay and Prevenir studies to show TDF's use and reduction of infections in this regard. But are we supposed to just automatically believe that Descovy is also possible for 211 without a similar study? So, you know, how do we guide people who are using 211 currently? And what I am kind of concerned about are, you know, some community folk that may experiment with Descovy without proper study data. Now, that happens with other medications, and some people are fine after that. But you know, I would much prefer having study data to help guide people with this in this regard beforehand.
Great. Thanks, Alan. It really does flag, I think, for all of us as a way forward to think about what are all the research questions. But I think, Monica, you said it really nicely, that this is not just we need research of FTAF for PrEP in cisgender women. We need it in many different populations that have been understudied or not studied at all. And there are a lot of specific questions. So it's not just thou shalt do, it's a question of what should be done. And actually it relates to a question that came in which I think is spot on. And no, we have no one from Gilead on the call, at least not as a presenter. I don't know if anyone is on. But a great question about how can we ensure that Gilead heeds the lessons of the positive studies like 082 and Partners PrEP and 3P that did engage communities generally and amongst cisgender women. And how do we ensure that Gilead's committed to community engagement and following the good participatory practice guidelines? And I'd love for someone to answer that. I think it is, though, a great question and one that we all need to be taking forward as a key priority advocacy item to push Gilead to do this the right way, because it's needed for this trial and it wasn't done in the Discover trial, as I think we all know. I'm conscious of time. I do want to flag one other quick thing, and that is some questions about what study might come next. And just to pick up on, Monica, your point, I don't know if you or Andrew want to comment on this at all. At least in the commitment letter that the FDA has required Gilead to conduct this study in cisgender women and adolescent girls, it says that the trial would include a Truvada arm, but it doesn't say anything about presumably not a placebo, and should employ two distinct methods to estimate background incidence as external controls. And it gets us into a new area of some of the innovative ways to do this. Hopefully, although this timeline is still slower than any of us would want, it's faster than a conventional efficacy trial. And wonder if either one of you want to comment on that at all.
I think a big randomized study needs to be done. I agree with the FDA. I think there are just too many unanswered questions. And I agree with looking at background incidence as well. Nothing else to add there.
Great, thanks, Andrew. Monica, I know you have to jump up, but any last thoughts from you?
I mean, I think that very carefully designed demonstration projects are also extremely useful. So I have to think hard about randomized versus demonstration, because I think these demonstration projects in women with TDF FTC gave us a lot of information.
Great, thanks, Monica. And I think a really important call that we should be collectively thinking about what is the research agenda we all want as a global community. I know again, some people are going to be dropping off, but I wonder, let me first thank Monica, because I know you're dropping off right at the top. But let me just see, Jeremiah and Judy, anything you would like to add to bring some perspective and closure, at least to this first of what we hope to be many conversations?
Oh, this is Judy. I'll dive in. Thank you. Yeah, first of all, again, thanks to Monica and Andrew and all the great questions, and Mitchell, your usual aplomb with mediating and moderating these things. I think really the big question is what kind of research and what research questions and what kind of research studies need to be done and can be done to answer the questions we really have. And I want to underscore Monica's recommendation to be inclusive of demonstration projects and for all of us to be thinking about alternative study designs to large-scale clinical trials, because we know those are becoming increasingly difficult, and as many, particularly in the social science world, have argued forever, they don't always tell us everything we need to know. So I think just putting in a plug for us to be thinking creatively and constructively about different methods and models of clinical related research and the adjunct social behavioral science that needs to go along with them would be really important and very helpful.
Great, thanks, Judy. Jeremiah?
Yeah, thanks, Mitchell, and thanks, everybody. This is such an informative webinar, and I hope, I know that this is being recorded and it'll be posted, so hopefully it's a useful informational tool for people going forward as well. And agreed, you know, I'm interested in bringing in transgender research advocates into this conversation. I know that I have seen some information from Atlanta Black Women Leaders on PrEP, I believe is the name of the group, talking about what their research agenda is. To really have a full understanding of everything that we need to learn the lessons from TDF FTC. We're still learning lessons about scale up for transgender women and transgender men, and we've lagged behind. So, you know, in all of this, we need to talk about, you know, really solid engagement of the most affected communities as this goes forward, to make sure that we're answering all of the questions. Because even in this discussion, you know, I think we have to be cognizant of who the voices are and who we need to continue to bring into this. So I'm excited for that. And one final point is I did see that Jim Pickett, I think you brought up the question of 340B pricing in the US. There are a lot of perverse incentives for community clinics, community-based organizations to actually advocate for a higher price drug because of rebates that help come back to our programs and help fund our programmatic work. And I agree. I think that's an urgent discussion we have to have in the US. I think we have to also push on our policy advocacy leaders here in the US, AIDS United, the Public Policy Council, FAP, to convene urgent discussions about this precise topic, because as soon as next year, we might see people making decisions about how to prescribe based upon programmatic funding as opposed to what's best for patients. So I think that's an important part to bring forward too. So just a few things to highlight.
Great. Those are super highlights, Jeremiah. And I want to acknowledge, I think, the issue of inclusion even in this call. And that's certainly something we want to look at the next webinar, or maybe multiple webinars. There are many different issues and many different populations we didn't even begin to explore. In addition to the ones you named, the role, you know, what we think about adolescence and issues there. People who inject are under discussed always when it comes to PrEP, and so many issues that we need to explore. I do want to encourage people to let us know. So whether following up on the email invitation to the webinar or being in touch with Dawn, Judy, Jeremiah, and or myself, what are the issues and topics you'd like to see discussed, questions we can answer in the short term, but also as we think about the next call or calls, what are the issues you most want to have flagged? We don't have a specific date for that second webinar. It will be likely toward the end of October. Stay tuned, but if you want to stay engaged, and we hope you will, and want additional topics covered, please let us know what those might be. And keep the questions going. I know Andrew and Monica have been incredibly generous in helping us understand the background. I also want to mention Angela Kashuba, who provided a great deal of input before the call, but wasn't able to join this call, who's a leading pharmacologist as well. So lots of resource people out there to help us all understand this. I do want to just come back to something at the very end, related to some of the things, Jeremiah, you just said, and Jim Pickett, you raised in the chat feature about what we can and should be saying as a community, and certainly about the research agenda going forward, how it needs to be done differently for TAF as well as for all products in development, but also just perhaps to make sure we move toward a clear community-wide message that says, you know, oral TDF FTC is the best PrEP for all option we have. It is actually the only PrEP for all option, because FTAF is not yet available for all, or at least not even approved for all. And again, making sure we watch our own language as well as the language of Gilead and providers, that FTAF is an additional option for some people. It is not better. It is non-inferior according to the research. It is no less effective than TDF FTC, at least for the people for whom it was improved. And it has a different safety profile, but any attempt to describe this as a safer, better PrEP is actually out of bounds, and I think we need to be vigilant as a community about that. There are many other questions we need to raise in terms of how they go forward with the study right now being discussed in South Africa. How do we do it better and faster? I think, well, I'll just say that one thing we can be pushing for as advocates right now, the post-marketing commitment that Gilead received from FDA has a final report of the South African trial by the middle of 2025. I know you all know that that is 6 years away, 6 years that are completely unnecessary in delay. Whether we think TAF is good or not, whether we need it or not, 6 years to wait is an enormous time, even with a relatively new trial design with historic control. So just want to flag that for all of us as we think about the way forward. There are a lot of other things, and we will hopefully keep this conversation going with everybody. But want to thank Monica and Andrew again, and really want to thank colleagues at TAG, the WELL Project, and WRI. We all are in this, and we need to make sure there are many, many more of us organizationally and institutionally involved, and really hold not just Gilead and the FDA, but all product developers and policymakers to account to do the right things, because clearly not enough of the right things have been done so far. So that's to state the obvious, but looking forward to working with all of you going forward. Again, please keep your questions coming. Feel free to send them, and if you have particular desires, needs, and wants in terms of what another series of webinars might cover, please do let TAG, WELL, WRI, and AVAC know, and we'll do our utmost to make that happen. Thanks again all, and have great rest of your days, whatever time zone you're in.
Bye, thanks.
Cheers all.